professor of ENT in Siena Medical School. She's a famous and a popular scholar in the world with over 400 academic publications. The topic Professor Bellussi is going to talk about is the metabolomics and AI in rhinology, promises and the limits. It's really a very innovative topic. So let's welcome Professor Bellussi.
Before starting, let me say that I'm really proud and honored to be part of this prestigious faculty celebrating Professor Sheng-Po retirement. Professor Sheng-Po deserves it. The title of my lecture is Metabolomics and Artificial Intelligence in Rhinology. Promises for our clinical work and, of course, limits. This is a table of contents. And we know that over the past 20 years, we have witnessed the transition from evidence-based medicine, which is centered on the disease, considering the prevalence of signs and symptoms, their severity, and also the efficacy of treatments is analyzed from an epidemiological point of view, with level of evidence or the number needed to treat. So this transition from evidence-based medicine to personalized medicine. Precision medicine, also called personalized medicine or targeted therapy or deep endotyping, is defined as the tailoring of medical treatment to the individual characteristics of each patient or the ability to classify individuals into subpopulations that differ in their susceptibility to a particular disease or their response to a specific treatment. In a simpler way, we can say that personalized medicine has as the main target to treat the patient, whereas evidence-based medicine treats the disease. The process of precision medicine is based on a deeper phenotyping of the patient, collecting medical history, lifestyle, physical examination, basic laboratory tests, imaging, functional diagnostics tests, immunology, histology, and multi-omics. Of course, more data collected together allow us to reach a deeper precision. The term multi-omics refers to the use of high performance technology to characterize a set of molecules relevant to a field of biology, such as inflammation or oxidative stress or immune reaction. As multi-omics approach follow the central dogma of biology, which illustrates the process of changing DNA to RNA to proteins to metabolize via transcription and translation. This approach encompasses a variety of works, such as genome, transcriptome, epigenome, that is to say, DNA modification altering the expression, proteome, metabolome, microbiome, and exposome. Summarizing, personalized medicine is an approach to studying disease etiology, pathogenesis, progression, and treatment that utilizes information specific to an individual to identify the optimal treatment option to that individual. Endotype refers to a subtype of disease defined by a distinct pathophysiological mechanism, in contrast with the phenotype, which describes characteristics of the disease without implying a different underlying mechanism. Multi-omics refers to the study of how different omics data interact to affect a disease. Metabolomics is a particularly difficult branch of omic science because of the amplification phenomenon. In fact, a single base change in a given gene can lead to a 10,000-fold change in endogenous metabolite levels because metabolites are the downstream products of multiple intracellular actors, including genes, transcriptional activators, RNA transcripts, protein transporter, enzymes, and so on. This clinical complexity means that metabolomic measurement requires a much wider range of equipment than genomic or proteomic measurement. For example, gene sequences needs only a single type of instrument, that is to say, a DNA sequencer. Metabolomics technologies are organized in sequential passages. The first one is the pre-analytical phase, which should be considered the most crucial phase and includes sample collection, transport, storage. There are some questions if, for example, sample should be frozen or collected in the right banks, or which anticoagulant should be used for blood samples. The second phase is the analytical phase, which make use of advanced technologies such as instrumentation, such as nuclear magnetic resonance, gas or liquid chromatography associated with mass spectrometry, and this last technical instrumentation, which almost unpronounceable acronyms. The post-analytical phase includes metabolite annotation and data analysis, which is performed with two different approaches, univariate and multivariate analysis. The last phase is the application phase to understand the pathophysiological significance of the result. And here you can see again all the process, the sample collection and processing, the chemical analysis, and the data analysis. The analytical phase allows us to recognize and dose a large number of small metabolites such as acid, alcohols, amino acid, sugar, fatty acid, cerol, but also drugs and toxins in different biological samples such as tissue, seed, plasma, urine, saliva, cerebrospinal fluid, stool, and also exhaled breath. In the analytical phase, nuclear magnetic resonance and mass spectrometry should be considered as complementary techniques. In fact, if on one hand, mass spectrometry, despite the strong sample, should be considered as the gold standard in recognizing and quantifying metabolites because of its sensitivity in a very small range, molar range, nuclear magnetic resonance can analyze the structure and concentration of molecules without destroying the specimens. Here you can see a gas chromatography mass spectrometry chromatogram of organic acids found in human urine. And you can recognize more than 100 chromatographic peaks corresponding to more than 70 organic compounds. At the end of this process, we can obtain our metabolomic profile, which is like a barcode, unique for each one of us, and giving us an enormous amount of information. We speak about fingerprints if we analyze and consider metabolites from tissue and blood, or footprints if we consider metabolites in urine and secretion. And here I wish to emphasize a further strength of metabolomics. In fact, this technique, with such a strong potential for providing information, can be used on samples collected non-invasively, such as urine, saliva, and even exhaled. Metabolomics is a revolution. In fact, the scientific process starts from an hypothesis, then the experiment, and finally the analysis of the results to confirm the hypothesis. In metabolomics, if we do formulate a starting hypothesis, that is fine, even better, but telling it is not strictly necessary. Once we have determined and dosed hundreds of metabolites, sophisticated software places these metabolites in descending hierarchical order, allowing to distinguish a healthy person from one who is ill, or discriminate an individual before and after a change in diet or the administration of the drug. Now, starting to consider the role of metabolomics in rhinology and HOSAS, the apnea-hypopnea events caused by repeated partial or complete collapse of the pharynx during sleep may lead to repetitive oxygen desaturation and several metabolic and cardiovascular consequences, such as increased risk for cardiovascular disease, arterial hypertension, diabetes, vascular dysfunction, as well as depression, are present in HOSAS patients. The slide shows all the metabolic pathways are altered in HOSAS. This is the reason why HOSAS was the first syndrome of upper waist approached by metabolomics studies, as you can see here from the research on PathOfNet. It is convenient for this reason to analyze the problem starting from the review published in 2021, in which data from the literature at the point quite consistent, even at the end of the selection of the eligible studies, are reported. In addition, the review considers and analyzes also the studies on upper airway microbiome and its importance on HOSAS development and severity. It should be considered this like a kind of multi-omic analysis. Analyzing the microbiome changes, the review shows changes in oral, nasal, and lung microbiome in HOSAS patients, a lower diversity of oral microorganisms, and a decrease of short-chain fatty acid-producing bacteria. Metabolomics changes are increased levels of anaerobic metabolites, increased levels of oxidation products, and disrupted lipid metabolism. Authors' conclusions are metabolomics can provide a snapshot of the changes in biochemical metabolic pathways associated with HOSAS, whereas microbiome profiling shed light on the interaction between an individual and his environment based on the immune response. Intermittent hypoxia and sleep fermentation may cause metabolic disorder and microbial dysbiosis. Although current research methods are somewhat limited, more multi-omic studies should facilitate the early diagnosis and treatment of HOSAS. Now, our experience. We are moving the first steps in this fascinating field. Few years ago, we started the level of oxidative stress biomarkers in healthy controls in patients with nasal obstruction, snoring, or sleep apnea. And these are our results. The level of biomarkers specific for oxidative stress examined by us were higher in patients compared to controls, patients with nasal impairment, although not statistically significant. The pathophysiological changes shared in HOSAS patients and nasal impairment may indicate the nose as effector in nodules development, and the study may be useful to differentiate mild OSAs from moderate or severe disease, limiting, at least in some patients, the use of polysomnography, and also helping the clinician in the choice of the most appropriate treatment. Going back to the last edition of the IPOS 2020, compared to the previous one, the edition of the 2012, the need of a precision medicine approach is stressed, with therapies addressed not to the symptom suppression, but rather to a personalized care, to prevention, with a higher patient participation. In the position paper, the most targeted therapy in eosinophilic chronic rhinosinusitis with nasal polyps is the use of biologicals, that is to say, monoclonal antibodies against inflammatory cytokines, but the treatment outcomes are still based on clinical parameters. This is the search on PubMed using as keywords metabolomics, chronic rhinosinusitis, and nasal polyposis. As you can see, quite recent and few studies. This is one of the papers published, and the aim of the study was to compare the serum metabolomics profiles between eosinophilic chronic rhinosinusitis, nasal polyposis, non-eosinophilic chronic rhinosinusitis and nasal polyposis, and healthy controls, phenotyping and endotyping the patient before surgery. Thus, we should consider the studies as a real perspective, predictive and preventive medical approach. Here are reported the top 10 most discriminant metabolites in non-eosinophilic chronic rhinosinusitis and nasal polyposis and eosinophilic chronic rhinosinusitis with nasal polyposis. As you can see, linoleic acid is significantly decreased in eosinophilic, whereas adenosine is significantly increased in eosinophilic chronic rhinosinusitis. As a whole, the results are serum level of linoleic acid are decreased and negatively correlated to tissue eosinophilia. Adenosine is the most indicative metabolite in eosinophilic chronic rhinosinusitis with nasal polyposis, reflecting the severity of tissue eosinophilia. For this reason, adenosine should be considered a promising biomarker for eosinophilic chronic rhinosinusitis and for predicting treatment outcomes. The research makes also an explanation of possible pathophysiological process in chronic rhinosinusitis. In fact, adenosine is accumulated during physiologic and pharmacologic processes, such as hypoxia, trauma, inflammation, playing an important role in modulating mast cell monocytes and T cells functions. This paper is a database allowing for comparison of patient-specific factors such as phenotype, endotype, but also medical comorbidities with chronic rhinosinusitis in relationship to microbiome composition and lipid mediator pathway regulation, opening the way to new therapeutical targets for specific subsets of chronic rhinosinusitis patients. In other words, the best personalized therapy for patients with chronic rhinosinusitis. Without any doubt, there are some limits to the immediate applicability of metabolomics in clinical practice. First of all, the need for precision. In fact, many of the published studies do not accurately mention the steps of the pre-analytical phase, how to collect and store appropriately the samples, and they don't make use of techniques considered as gold standard, such as nuclear magnetic resonance or mass spectrometry associated with gas or liquid chromatography. Until now, there are no standardized protocol for all the procedures, and concerning the discovery phase, most other studies have a number of subjects recruited under 30, condemning them to the status of preliminary phase studies with little applicability in the diagnostic and therapeutic field. How can we overcome these limits, bridge these gaps, starting from scratches? That is to say, starting in the data analysis, first physiology, then physiopathology, clinics, and therapeutical solution exactly in this order. Then controlling the validity of clinical trials, choosing adequate samples, a control group, using external or internal standard or a combination of both to monitor the quality of the results, and making use of standard procedures. In addition, we can make use of data banks, as for example, the database I previously have shown, or using artificial intelligence and machine learning as new approaches to an increasing number of data. Our conclusions are that the application of metabolomics to develop a tailored medicine should be considered crucial for identifying the mechanism and the origin of inflammatory disorder of the nasal and paranasal sinuses. Today, metabolomics in our field in rhinology should be still considered as a research tool or at least an emerging technology, but we hope it will be soon incorporated into the clinical labs. And the bottleneck to advance in the field is the complexity and the lack of standards protocols or best practice for metabolomics experiments. I thank you for the attention.
Okay. Thanks, Professor Bellussi, and all the attendees to join us this morning. Due to the time difference, Dr. Bellussi is unable to join us online. But from the talk, we understand that there are increasing applications of metabolomics and AI in rhinology. Metabolomics can help us differentiate endotyping of CRS. Next step, maybe we will entail multidisciplinary collaboration to ensure the data integrity, ongoing validation of AI algorithm, and integration into clinical practice. It is totally different scenario and will be a whole new world in rhinology. So now we open the question to the audience and the comments. Is there any comments from the audience? Maybe we will transfer your comments to the Professor Bellussi. Is there any comment from Professor Sheng-Po Hao?
Well, thank you, Tiger, for your introduction as well as you hosting the moderating the section. I think Professor Bellussi is an old friend of us, and actually Professor Luisa Maria Bellussi was here in Taiwan just last year. There's a Italy-Taiwan combined rhinology conference held by the Taiwan Rhinology Society, and so we would be very happy. We have build up some communication and bridge between the Italy and Taiwan, and we know that Professor Bellussi's husband, who is Professor Passari, is also a very good friend of us, and so by Professor Bellussi and her husband this area, particularly Taiwan and Italy has been, helping each other and to, improve the, standard, not only the standard of care, but the, translational research in rhinology, which will be very important to moving the rhinology, especially in the new era of AI, the artificial intelligence, and helping using the AI to help to evaluating the to analyze the data, the huge amount of data, and to get into some, for example, some biomarkers, and which could be used to predict the treatment outcome of the chronic renal sinusitis. So today, Professor Bellussi's lecture would be just a wonderful and a very provoking, lecture, and this is really an excellent, not only for the beginners, for the residents, for the fellows, but also because the AI is a new era, a new Brucey, even for a an old surgeon like me, or rhinologist, or ENT doctor like me. We still could learn a lot from Professor Bellussi, and really look into this issue and try to move in the ENT field ahead. So thank you, Professor Bellussi, for your wonderful lecture. We look forward to listen to your more excellent lectures, and working together with us. I believe the Italy and Taiwan are very close. Actually, right, it's not too far away. It's actually 10 hours, from Taiwan, from Taipei, flight to Rome. However, I think our heart will be always together. So thank you, Professor Bellussi. So Professor Tsai, back to you. You want to explore more comment, or go ahead for the some of the introduction?
Okay. Yep. Okay, thank you, Professor. From the talk, we know that the metabolomics is really important, can help us to analyze a lot of clinical data, and importantly, to tell us the endotyping of the chronic rhinosinusitis. I think it's a very promising research, and will be helpful to our clinical work. And so today, due to the time limitation, I will going to close the section. We thank you for your.
Before we close the section,
Okay.
I'm sorry, Tiger, to break into your talk. I just give you some idea. For the next week, we are going to have Professor Chong-Won Baek from Korea to give us, a talk on the evaluation of tongue cancer treatment, and also Seimo Shinji, another giant in rhinology. He will talk about the fundamental of rhinoplasty. And my friend Isaac Brew, he is a survival of the cancer, and he is going to talk about something very different from what we heard in this series, which is the life challenges facing laryngectomies. And in the last in March will be Dr. Lin Chi-min from Singapore. He will talk about one of my favorite topics, the surgical paradigm in treating recurrent MPC. And we welcome you all to join us for this Dr. Sheng-Po Ho retirement virtual one. And hope you have a good day. And thank you for participating. Thank you for supporting. And thank you for Professor Bellussi for your wonderful talk. Thank you.
So thank you, everyone.
Okay, bye-bye. Have a good day. 好，泰哥，谢谢。那我们还有一点时间，就开半个钟，我要开一下 morning meeting。好，谢谢。他讲的很好，他是很刻意的去，很刻意的去